The center of the room is always the patient and their bed, and all your equipment will surround the room. You've got wall suction, oxygen on both sides, and we can have suction on both sides if we need to. IV infusion pump in the corner. It's wrapped because it's been sterilized. We call those a cardiac chair, a place for them to get a chance to get out of bed and relax. They can put their feet up. They can eat their meals either in bed or there. We got a little desk and of course television. That's the operation board where we have the identifier of the patient, how they want to be referred to, and then the basic plan of care, whether we're managing pain or we're looking at ambulating, walking status, physical and occupational therapy, work with them. That kind of has all the details that need to be completed until the patient can be discharged. What barriers they have to discharge. Also have a walker in all the rooms. This is a sofa that pulls out into a sleeper sofa for family. We are currently on level 2 lockdown, so we don't allow overnight visitors. When the pandemic first hit, we were on level 1 lockdown, and the hospital had no visitors.
Thank you.
The room for full orientation status. Sometimes patients get confused for being in the hospital, so it tells the time, the month, the date, and the day of the week. And it's just a simple tool for a patient to keep oriented. Staff's computer system they use. They got a badge access. I'm going to touch your badge to it. It'll access. Bring up the electronic medical system, and then we scan the patient's wristband, and then we ask them what their name and date of birth is as second identifier, and then we scan each medication. And the barcode on the medication has to match what the computer says. And that way we know that we're giving the right medication to the correct patient. On the wall here we have suction set up first, which is standard for any seizure patient to have that set up. And on the left is the oxygen. We would just attach tubing to that, and then to the left of that is the call light system. That's attached to the call light itself. It's right there. And that's what the patient would hold. They can control the TV, they can control the lights in the room, and they can call their nurse or the tech based on what they put. The call light in the wall system has a quick, easy release where we can press staff assist if we want more staff in the room, or press a code in case the patient's heart rate stops or they stop breathing. And that goes through a pager system, and we'll have respiratory therapists and physicians up here in a couple minutes. My responsibility would be to bring the crash cart in and have staff start CPR on the patient, and have the pads attached to the patient so we can shock them if they have a shockable rhythm, such as ventricular tachycardia. This is a standard code cart that we have on the floors. The most important thing is the defibrillator. The initial thing we do with a patient who stops breathing or heart rate stops, we put this underneath them. And in the same motion, we have 2 pads in here. One goes on their front and one goes on their back. So we turn the patient on the side, slide this board in one motion, put these pads on. These will monitor the electrical activity of the heart and the heart rate itself. The monitor will tell us what heart rhythm they're having on the screen, and will indicate if we need to shock the patient. Otherwise, we're looking at the rhythm, determining what medications we can give to the patient to get back to a normal sinus rhythm. Otherwise, the code card starts out with medications on the top, and then we have all supplies that we need to start IVs, bag a patient, put artificial airways in. We also have portable suction on the card itself.
What is suction used for exactly?
Suction is for the oral airway, as we'll have a bag mask which will go over the face of the patient, and we're actually breathing for the patient while we're using this. And if they have a lot of oral secretion, saliva, by doing this, that could go into their lungs. So we use suction to suction out their mouth in between using this. It's still the most recent studies have indicated that the compressions are more important than the actual breathing. But the breathing is a important component, but if you can't maintain an airway, the compressions are more important to do, because you're circulating the blood to the organs, and any medication you're giving them through their veins intravenously is pumped throughout the body by doing chest compressions. First, the side of the cart, got an oxygen tank, and that's the respiratory bag, so we can intubate a patient, where we create an airway by going down their mouth into their lungs, and it has a special light on it, so we can enter the tube and go past it by purification, so we're getting the tube into the lungs and not into the stomach. And of course, with the newest thing, since we're in a pandemic, this goes with the code card now. It has gowns, gloves, face shields, and of course the N95 mask in it. And that goes along. And then of course we have a manual blood pressure cuff, which would also go. So I would send, in the event of a code, patient stops breathing or heart rate stops, send staff members to get all these these things and bring them to the room. And
This is for the COVID patients.
all I do is, as we have more, I move the signs down the hallway, and as we have less, we move them farther down the hallway. Last week I had these signs all the way at the end of the hallway, and we were using this whole hallway. The current protocol now is the patient's admitted with symptoms. We're looking at gastrointestinal systems such as diarrhea, nausea, vomiting, and or respiratory, shortness of breath, fevers, and those patients are admitted as PUIs, which means person under investigation. They come here, they have initially a rapid test that's done in-house, which is a nasal swab, and that goes to our lab. It takes about 30 to 45 minutes, and then we get a result back. Depending on how long the patient has had symptoms and possibly the virus itself, those tests, we've had a lot of false negatives with them, with the rapid. Part of it is that maybe the swab wasn't done well, using the nairs and getting a good collection. Maybe it wasn't as advanced, as the virus hadn't advanced enough to go up into the nasal pharyngeal area. And then they're admitted to the unit. We're monitoring symptoms. If that test comes back positive or negative, we'll still keep them in the hallway. If it's negative and their symptoms have resolved, we can move them out of the hallway into another part of the unit or another part of the hospital. And if they're positive, of course, they'll stay there and we'll treat them medically. If it does come back negative and they still have symptoms, then we'll keep them there, and 24 hours later we'll do another swab and we'll send it out, which is supposed to be a more sensitive test, but currently can take up to 36 hours for results. And we'll keep the patients there until they test negative, and we don't test any more often than once every 24 hours. Example of infusion pumps. We got a walker on the left and a commode on the right. And, seizure pads. If a patient's admitted with a seizure diagnosis, we put those on the bed and monitor the patient. We can do a continuous EEG on the patient, where we put monitoring stuff on their head and have a camera in the room, and we monitor them for seizure activity. These are our fancy contact precautions. Those go on outside of the rooms that the patient's on a contact precaution. So staff has all their PPE they need right there. With the current pandemic situation, we have the PPE is controlled by the charge nurse, and it's next to the charge nurse station. We'll see that soon. This little guy is called a kangaroo pump. This is for people that are having difficulty. They may have a mouth injury or upper neck injury, and this can pump nutrition through their nose down into their stomach, or they may have a stomach tube called a gastric tube, and this is how they would get their tube feedings, as we call them. This is a sequential compression device. We call it a SCD for short. It's a pump, and it connects to the patient's calves, where they have a sleeve around each calf of their leg. And it alternates right and left, and it helps facilitate the venous flow of blood back up to their heart. Once you're relatively active and you become sick and you're in bed and you're unable to ambulate or walk as you normally would, the increase of developing a deep vein thrombosis or a clot in the calf area of your leg increases very highly. Some of your folks that have raging fevers or other situations are hooked. This actually hooks directly up to the bed, and it helps circulate cool air throughout the bed to help decrease the fever and keep the patient cool. And if they have some kind of medical condition or disease process that's making them sweat profusely, this helps eliminate that factor also. Because wet skin tends to break down quickly, and then you have skin ulcers. This is our PPE cart. We have a small and regular N95 mask and the NOS mask, small and regular. We keep about 10 of each here. This is really to just keep an eye on the supplies we need, and I would invent if a patient code, I would wheel this down to a patient room and hand this out to people as they come to the code. We also have regular masks. The yellow, the blue tend to fit a little looser, and their ear strings are a little bit longer. And of course, we got our gowns. On the bottom, we have the face shields and regular brown paper bags, which we keep our PPE in. We use it and then we put it in the bag, and it's considered dirty. We can pull it out of the bag if we need it, clean it and use it, and then we throw the bag away because the bag is dirty.
What's this?
This is a glucometer. We'll take a small sample of blood from the patient, and it'll show what their blood glucose level is. Want me to see what yours is?
No, thank you.
You take, and this has a needle inside of it, and you just prick that down on the patient. Does a quick little in and out, and then you got blood. We'll do a squeeze. We'll wipe it off with a gauze, and then squeeze again, and you got your true sample to use. Just put that up to the blood, and within 6 seconds you have what the patient's blood glucose level is. Let's stand to sit. Stand to sit and lift. We get a patient in there, we strap their legs into it. They got straps going around them, and it lifts them up so they can stand. And it may be something as simple as sitting in a chair and getting them in bed, or helping them stand and put weight on their legs while they're semi-supported by the lift itself. Here's another example of a patient room. IV pump in the corner. We have the wall suction, oxygen containers, locking sharps container. Anything that's got a needle that's sharp, it's got a one-way entrance in the top, and then it's locked. Bedside table. This can serve as something if they're in the cardiac chair, or they can use it in bed. This contains all the supplies that we use on the entire floor, including the blanket warmer.
What's in this one?
Same thing.
Wow.
And we got our trauma cart. If we have a trauma patient up here, we can remove sutures, we can do casts, whatever we need to do with a trauma patient, put in chest tubes. Different bladder scanners where we use a probe and we put that on the lower abdomen of a patient, and we can scan the bladder and see how much urine is in there in milliliters. It's really a tool, a lot of pain medications and or if they're having any urinary tract surgeries. Bladder retention is a big issue. The one on the right is a glorified bladder scanner that's nearly an ultrasound. A lot of times we're pulling patients' Foleys out. They start a timer that they have 6 hours to urinate, and if they can't, then we'll put a catheter in, drain the bladder, then pull that catheter back out and start that 6-hour timer again. A lot of times anesthesia, pain medication can make it difficult to urinate.
What's this? This bad boy.
And that's the Foyer lift. This has a basket that attaches to the rings, and you can actually put that underneath the patient and lift them out of bed, put them on the commode, put them on a shower chair, put them on the bedside chair, and help also get them from wherever you need to. Also has the legs will spread out to accommodate underneath the bed to get to go where you need to. Not on this floor, but some floors have a bariatric pulley system in the ceiling that helps get the patients out of bed and anywhere in the room that they may need.
What's this guy?
This is the electrocardiogram, also called an EKG. We hook up these 12 leads onto various parts of the patient's chest and various parts of their body, and it shows what the electrical rhythm of the heart is. And this is very detailed, gives us diagnostic information to determine what kind of medications to put the patient on, or if the treatments we're giving the patients are working towards getting back to a more normal sinus rhythm. It also has a scanner function, which you can scan the patient's badge. Scan the patient's badge, and it'll bring their name and their information up on the computer, so you don't have to manually type it. So this is a standard vital sign machine. We have our oral thermometer. We have a temporal thermometer, which we run across the forehead to the neck, and we can also get a reading with that. Of course, this also has a scanner for the patient's ID. This is pulse oximetry. We put the patient's finger in there and it'll show their heart rate and their oxygen saturation. And this connects to the blood pressure cuff, so we can get a blood pressure on the patient. What sets this hospital apart from others is most hospitals have to write down the information that's contained in here and manually enter it in the computer. This hospital and this equipment has the function to send it, and it automatically goes right into the electronic medical record, eliminating the chance of errors, wrong patients, wrong numbers. A lot of patients with congestive heart failure, where their heart can't pump well enough. So we have to eliminate the amount of blood circulating in the system to make it easier for the heart to pump. The quickest indicator that the patient has too much fluid is taking their weight the same time each day. We choose a generic 4 a.m. and you have a plus or minus a couple pounds to allow for hydration, water weight. But in general, if there's any significant weight change, you know the patient is fluid overloaded, and you'll have to give medication so they can eliminate that extra fluid from the circulatory system.